the opposite sex parent. For me, just like my mom, any woman that was condescending and castrating was just right for me, Add blonde to that, sometimes that helps. But, when you look at this, it really is revealing, because what you'll see in this is that they're literally picking out, often an abusive adult. And you can see that, for example, the relationships here, how similar some of these things are. And it's a nice point to show the patient that, yes, in fact, the past is still here, and that the things that happen to you in early life affect you in terms of your health, your well-being, your serenity, and your relationships. And remember, one of the things we led off with is that, we talk about recovery as an individual journey. It has to, you have to be somewhat selfish, I guess, at first. But it happens, although we have to do it ourselves, it happens best in community. It happens best when we're surrounded by others who are, of a like direction. So as we look at some of this, probably the area that's been very interesting for us, and we're still nowhere close to resolving it, is what do you do with trauma survivors, who have alcohol and drug problems? Is there a length of time you need to wait? See, from my perspective, if there's two things here that I would really consider in terms of putting them to that program. When I first started doing it, it was back in about 35 years ago, I guess, a little treatment program in Florida. And what we did was we created a kind of a CODEP trauma sort of thing. And I started noticing several things. They say anger is often the last emotion a person has before they relapse. So I'm looking at this, okay, if angry, hungry, lonely, tired, and we get the group to start to talk about this, and the angry ones just turned out to be trauma survivors. The group went from an anger group to a trauma group. But in trying to conceptualize this, probably the difficulty with trauma has been one that we still have not really resolved. I think, if nothing else, it's very important to have your environment friendly. There's so many nuances. Think about if you're an inpatient treatment, you're a trauma survivor. Let's say a family member used to sneak into your bed late at night. And you'll see some of the kids will pee in their bed as a deterrent, and they'll continue to do that later in life. And you start to notice that in a treatment program, for example, that patient may be in their bed asleep, and what happens about midnight when someone opens that door and starts to creep in to, check on them? It can trigger those events. When you look at your borderlines, your really disorganized attachment, when they have an experience that in any way reminds them of the trauma, they go back and basically relive it again. And it's, all of these things are potential levers to try to get a person to look at the trauma. The thing about it is that they have to be ready. My deal is very simple. Is it safe to do this? Is it safe? Do no harm. See, in an inpatient program, I can do a lot of things because I got support. I can watch them if they get a little self-destructive. We have people all around them. On an outpatient basis, it's a little tougher. But on an inpatient basis, it was pretty easy very early in recovery to move them through a little protocol to develop. And it, I guess the part of this that is important, let's say you've got someone like Peggy, and let's say that right now she's being treated for her addiction. She was a cocaine addict, alcoholic, and we're thinking about adding a new component. And if we stay with Peggy's story, when she comes in and tells me about what happened and how that was not normal, we started to talk about it, and what that led to was what happened to her when she was a child. You sometimes guess maybe it was Dad. You play the odds. Her older brother was the perpetrator. He was about 4 years older than she was, and starting at about age 9, he started molesting her. So now, what has happened is that if I can get Peggy to be willing to do this, then what I'm going to do is implement, the treatment piece. But in doing that, there's several things I think are important, and this is the trauma piece. But as we understand it, they're all connected, right? They're all co-occurring. They all connect to each other. Maybe drugs in some way is a way to help me manage, some of the feelings and other things from the trauma. So as we look at this, we have to make sure that we integrate it in. But the other thing is that what I found with trauma survivors is that sometimes if you're not square with them, if you really don't deal with them up front, and you just start to implement something like an exposure technique, what happens is that when they start to have the bad feelings, I've had several situations with therapists where the patient said, if I knew it was going to be this bad, I would not have gone through this. And so what I'm looking for is a tacit acceptance of all of this. And the way that I do that is psychoeducationally. And psychoed gives you a lot of leeway. Basically, it's educating the patient, but also processing what's going on. How do they feel about this? What questions do you have about this? And so what I do is I explain to them several things. The first is I want you to run a stronger recovery program. I've actually used a sponsor as a significant other, and depending upon what the client wants to say, we could just say things to the sponsor like Joe or Peggy's going to be going through some tough times in therapy over the next weeks, and we just like if you would keep a closer eye on her. Maybe a phone call in the evenings, or making sure she's going to meetings, and maybe let's add a meeting or so, because if the alcohol drug piece falls apart, everything falls apart. And so I've got to keep that going. And then what I do is I explain in the best detail I can what we're going to be doing to address the trauma. And I want her to understand that there's going to be pain involved. You've been keeping that stuff with you for a long time, and a lot of it's very painful. And so we go through it, and I want that person, in this case, Peggy, to agree to move forward, with the work. Because that way, I'm not so concerned about them coming back to me and saying, you didn't tell me about this, I didn't know what we were doing. That stuff has been dealt with, right up front. So when we look at something like this, I'm going to talk to you about what's called complex or complicated PTSD. It's more of what we see in our population of people who are, kind of multi-generational trauma, repeated trauma, these types of things. Acute and chronic effects of hyperarousal and dissociation. I want to show you some of the things that happen that hopefully can explain some of the things you've seen in these clients. The aspect of treatment and recovery, and we also have self-injurious behavior here, which a lot of that is done by trauma survivors, especially your borderlines. Because we're talking about it now, if you have, when your borderline patients will do this especially, what they'll do is they'll call. I get this call from the answering service, and I call up Peggy, and Peggy's, you need to scrape her off the wall. She's all over the place. She's thinking about hurting herself. She's thinking about drinking and drugging. And what I try to do with that is, as they say, first affirm it. I can tell by your voice how upset you are. And I'll talk to her a little bit about that. And I'll say, in order to help you, I need for you to give me a little information. So I say, I want you to go back to this morning and tell me what led up to this feeling you have of needing to relapse or to hurt yourself. Because there's probably some little interpersonal slight or something that's been blown way out of proportion. And the thing about the first thing we're doing is we're shifting blood flow in the brain. Remember we talked about I over E? When she came in, she was definitely E over I. And basically by having her talk, will change the blood flow. Having her converse, talk about these things, label them, whatever, will actually start to reverse this, as we talked about yesterday. So, when we start to look at this, I hope that in a while what we'll do is I'm going to go through a few things, and then I'd like to just take Peggy's case and just roll it out, and some of the decision points and some of the things you do, and maybe a little bit about using behavioral exposure with an attachment narrative and the philosophy of all of that. So I'm hoping we can accomplish those things. Okay. If you look at PTSD and you look at DSM-5, you got the hyperarousal, the avoidance, the intrusive stuff like nightmares and flashbacks. And, if you, when we look at this and we start to look at something that has started in early life and was often multi-generational and traumatic, then what we see is complex PTSD, which the first time I ever read about that, it was like a eureka experience. A lady, Dr. Herbert, I think was her name, but anyway, she wrote a book called Trauma and Recovery in 1991. It was the first time I'd ever seen the word complicated PTSD. So when we look at this, it's like a three-legged stool. One leg is the physiological stuff, the actual physiological changes that you're going to be going through or going through. The second leg is self and identity. In other words, when you look at especially someone with a disorganized type of attachment pattern, they generally have boundaries that are like amoebas. They don't know where they stop and you start. They project things into people. If they're feeling something, they often project it into someone else. I had a lady once, she had a cold or something, and she walks in the office and she says, I hear you're sick, I hope you're feeling better. And that was the first time I knew I was sick, and it hadn't dawned on me before then. But, it's just projection. And this, if you want to read about it, Salvador Minuchin in 1974 described it very, very nicely. Enmeshed families and disengaged families. What we've got here is an enmeshed family with boundaries like amoebas. And, when we start to look at the other piece of this, we've got self and identity, and we've got problems with consciousness here. And we can call this dissociation. So it becomes more of a three-legged stool, and we would kind of expect to see some physiological changes, some self and identity changes, that when this is fulminant, this is your borderline personality disorder. And I think that, when we start to look at this, dissociation is something that is sometimes hard to grasp. But remember we said that opiates create dissociation. And dissociation allows me to deal with my emotions that are overwhelming me in a way where I distance myself from them. You know, I dissociate from them, I shut them off. And as we look at this three-legged stool, each of these different areas has certain things that we need to pay attention to. Like physiologically, we've got affect regulation problems, impulse control problems. You might have anger issues or whatever. You can have somatization and medical problems. The problem with trauma survivors is that a lot of the difficulties they have are not perceived by physicians as always legitimate. Some of them are perceived as malingerers, and other horrible little handles they get labeled with. But you know, you look at all this, and I can tell you that a lot of problems that you're going to have, GI system and other problems, are going to be directly related to the trauma and what's happening physiologically. When we look at self and identity, you know, they just see the world differently, very differently. And, you know, as I said, the trust issues, the power issues, all of these things come to bear. And what we're trying to do here is to kind of help them as best we can to be as functional as possible. One of the things that I do with borderlines that's really been helpful is because they don't have a great sense of themselves, who they are. I mean, that's kind of a loaded question, asking someone with trauma survivor with borderline personality disorder, who are you? They'll look at you like that's the craziest thing I've ever heard in my life. If they say something good, it's a third-hand report. Someone once told me I was a nice person. There's not many I statements in this. You know, they tend to be more negative, and so when they start to talk about negative things, we can certainly see that in them. And I think when we sort of put this together, it can create a number of problems. And what I want to do is first understand it, and then we can talk about, you know, ways of managing it. But if we looked at different types of approaches here, let's look at, let's say you've got a recovering alcoholic or a meth addict, and let's say that they are a trauma survivor. And, you know, what happens, they're in early recovery, they're doing okay, all of a sudden something happens that precipitates a crisis. Some stimuli reminds them of that old hurt, and they will either go into a hyperarousal, which we call flight or flight, or dissociative mode. Both of these have relapse written all over them. You know, what I want to have happen, if we can successfully treat them, is that instead of this sort of arousal, that it's like a bump in the road. You know, they feel it, they know it, but it's not overwhelming, and they can continue on their recovery path. And so that's part of what I'm hoping to achieve. But you know, when they go into these particular you know, survival patterns, you know, it just invites relapse. And some of the things they do, you know, they'll feel bad about, and that also invites relapse. So in looking at this, we could talk about hyperarousal, and some people have more of a hyperarousal mode. They're very hypervigilant, reactive, their heart's beating a little too fast. In other words, their sympathetic nervous system, their fight or flight nervous system is controlling things. Remember yesterday I talked to you about parasympathetic tone, being able to regulate the sympathetic system through the parasympathetic system. We talked about everything from little infants and suckling. It was one of the examples. I think that, you know, when you start to look at this is a lot of wear and tear on your body. This really is. When you run a high sympathetic profile, you're keeping your body and brain in a constant state of fight or flight. It'll wear you out. It'll burn you out. In terms of, The people who tend to be this, older children, males, I wouldn't put too much money on that, but just as a general piece, it works. Norepinephrine, for example, is a stimulating neurotransmitter. Let me just thinking about norepinephrine, and let me show you something about opiate addicts. When an opiate addict goes into withdrawal, did I talk to you about, I think I did talk to you about the locus coeruleus yesterday. And, well, tell me if I did, I don't always remember. This place called the locus coeruleus, or the LC. And let's just look at the fact that you're a heroin addict, meth addict, whatever, in this case heroin. And this particular area is the start of what's called the reticular activating system. It's the reticular activating system. It's an alerting system. When you wake up in the morning, your brain will kick out norepinephrine and cortisol, and that's to get your body cranked up in the morning, to get you moving. That's also why we see a lot of heart attacks and strokes in the morning and arguments in the morning. All that cortisol will do that. If you've ever taken something like prednisone, you know what it can do to your personality. It's not very nice. So let's just imagine that this is, determining our level of alertness. And let's think of that level of alertness as a spring. Now, I inject heroin, and what's heroin going to do that spring? Going to depress it, right? Because it's a CNS depressant drug. So in order to maintain homeostasis, to keep things within a normal range, the locus coeruleus kicks out a stimulating neurotransmitter called norepinephrine. This is called tolerance also. So when you look at this, what is happening is that the brain is compensating for what the drug is doing in an attempt to maintain a homeostatic balance. And so what I have to do as a heroin addict is I'm going to have to take a little more heroin to get to where I want, at least in terms of this particular aspect of the high. And so now I've got tolerance, and we start to look at what the LC does. It kicks out more norepinephrine to try to compensate for what the heroin is doing. Now, what happens when you take the dope away? What do you have left? A lot of norepinephrine, don't you? So what we do is we call them vital signs. We measure heart rate, respirations, pulse, things like that. All of that is coming from here. This is driving all of it. The norepinephrine is putting you into fight or flight. At the same time, in withdrawal, your immune system kicks out a lot of cortisol. Cortisol makes you feel irritable and discontent. Okay, it's a pretty big player in addiction. So when we look at something like this, we can start to see how norepinephrine might work in some other ways here, but it's that hyperarousal, more the fight or flight. For dissociation, you actually get a lowering of heart rate quite often, and it, as I said earlier, it's endorphins induce this. It's induced by endorphins, and so you take external endorphins like heroin, and you put it in the body, and it allows you to dissociate. As I mentioned earlier, for trauma survivors, it really works for them for a while. It's like being loved and cared for and fed, and you get the dopamine and all the dissociative pieces, and it can seem at first blush pretty helpful. Now, if you look at dissociation, you tend to see it in younger children and females, but you'll see all sorts of things here: derealization, depersonalization. In other words, you might have people who tell you that even in a crowd, they don't feel like they're a part of it; they're removed from it. And so when we look at something like this, there is the system that causes us to engage, which is the sympathetic norepinephrine fight or flight, and there's a system that causes us to disengage and to build up stores and things such as that, and that is our parasympathetic system. And so when we start to look at that, I was mentioning yesterday that it's important to have either a parasympathetic-sympathetic balance, or to have the parasympathetic piece a little bit more, working a little bit harder. And it will be quite helpful, because what it'll do is it'll knock out a lot of these hyperarousal symptoms. So as we look at it, we can see that there's things that we know that can happen here. And let's take it a step further. Let's look at some of the physiological things, and I want to just use two examples. And I'll preface it by saying that in a pain clinic, for example, we had 200 women, all of them who claimed to have been abused early in life, a good proportion sexually abused. And what we did with them was we checked them. We looked at their diagnoses, and a lot of times what you'll see is autoimmune problems, and I'll show you why that's so. And then what we'll do is look at it from an acute perspective of what happens in the long run. We'll look at the same thing with dissociation and cortisol, and you can start to see that this early trauma has its own legs. It has its own momentum. And so if we looked at the acute effects of hyperarousal, a lot of norepinephrine, adrenaline kicked out, fight or flight. In the short run, it reduces pain through endorphins. And what it does, and I'm not sure exactly why, but the way our system is built is such that when we are in a situation that is frightening, and we can go back to the old caveman and the saber-toothed tiger if you want. I mean, the way we're hardwired for that. And so what happens is, say the saber-toothed tiger bites one of the cavemen, and so what happens is his body starts to kick out a lot of cortisol and some other things that will hopefully keep him from bleeding out before he gets back to his cave. So we can see that in the short run, we don't see the immune response. And from a survival purpose, I think what is happening here is that the immune piece is not considered that important right now. Survival is the big deal. If you can't survive, you don't worry about the infection. So if you look at this, what we see is decreased immune response, and cortisol reduces inflammation, we know, but cortisol suppresses the immune system. So you may have someone who has a lot of little infections, chronic sinusitis, upper respiratory tract infections, things similar to that. Now, when we look at this and cortisol suppresses that immune response, then it can set us up for problems in terms of viral, bacterial diseases and other things. Now, if we took this a step further, instead of saying the acute effects of hyperarousal, what if we look at the long-term effects? Because the data was really confusing. When I first started looking at this, probably in the 80s or so, what I was finding was a lot of research that said that people who are trauma survivors have high cortisol levels. And then later on, I read reports that said, no, we see a lot of them with low cortisol levels. So I'm going like, what's the deal in this? I mean, which is it? Well, it's actually both. What happens in this is that, that when this becomes chronic, what happens is that your adrenals become exhausted. And your adrenal glands are the ones that put out cortisol. So secreting all this cortisol over years and years and years can lead to adrenal exhaustion. Your adrenals just get worn out. And so what happens with this is that when cortisol goes down, you'll see a lot of effects, but the biggest one is the immune system. The immune system goes haywire. You can actually feel sick without being sick. See, the immune system creates the symptoms that tell us we should rest, like it makes us tired, it gives us fever, it gives us other things to try to tell us that we need to take a little bit of time, we need to, get a little help maybe. And so when you look at this, all of a sudden the immune system's gone haywire. And this is where a lot of your autoimmune diseases come from. We see an awful lot of them in trauma survivors, from everything from fibromyalgia to arthritic conditions to Crohn's disease, which is a very nasty bowel autoimmune problem. And so you see, the thing is with this is that we're going to see, these sorts of things because there's a rebound effect. And, when that immune system kicks in, you may have all the symptoms of sickness, but not have any cause for the sickness, like bacteria or virus. It's just that system cranking up. And when we were looking at the pain patients, what we did was history of trauma. We looked at the diagnoses. A lot of times they were autoimmune, everything. We had a lot of fibromyalgia. We had other things, arthritic conditions. And what we tended to look at in that was with this combination that they were hurt early in life, and looking at the diagnosis. And the question I had was what their cortisol levels would look like. And most of these people are now we're looking at are in their 30s, 40s. So what happens is that adrenal gland becomes exhausted, cortisol goes downhill, the immune system just takes off. And so what you have is a heck of a lot of inflammation in your body. And inflammation is probably what kills most of us. It's involved in obesity, it's involved in diabetes, it's involved in heart disease, it's involved in stroke, all sorts of things. So what we see is that your whole body can become inflamed. I was traumatized twice. I mentioned a little bit yesterday, and I have rheumatoid arthritis. And I was not even diagnosed until I was 50. I kind of tracked these things back. I think it was just the changes in the system that probably set this up. So if you look at some of the chronic effects of hyperarousal and what they do with cortisol in your immune system, you can see a lot of things going on here that are difficult to manage sometimes. Now let's look at the acute effects of dissociation. Now remember, in dissociation, we said that dissociation tends to be mediated by endorphins. So what we've got is our own internal morphine, our endogenous opioids, and these are things that that we've already talked about quite a bit. But these are your natural, I guess, ways of precipitating dissociation. And what we said was endorphins are very much involved in this. And I mentioned yesterday some cases where people, when they were injured, because they got so much endorphin release, it was 30, 45 minutes before they really recognized the pain and the need for help. And so when we look at this endorphin piece, what we're going to see is that acutely, we're going to be putting out a lot of this. We're going to put it out. And what it's going to do is, what we're going to do is try to increase that parasympathetic nervous system. And when you look at the increase, you get the decreased heart rate, respiration, blood pressure. So these are things you'd see with dissociation. But then we see all the endorphins, all the inflammation, and what the impact that has on the body. And what was confusing was it depends on when you measure cortisol. If you measured it pretty early, in their life, you'd probably find elevated cortisol. But if you do it later in life, you might find hypocortisolemia. low cortisol in the blood. Hypocortisolemia can mimic every symptom of PTSD. Low cortisol can mimic all the symptoms of PTSD. So there's a lot of things happening. So acutely, we can look at this and we can see that you know, what it is doing and how it might be, you know, how we're using the endorphins, you know, and dissociation as a way of coping with things that happen and feelings that, you know, are you just can't tolerate. Now, if we looked at this is the acute effect, right? Now let's look at the chronic effect. You just deplete your supply of endorphins, you burn them out. So what do you do then? Whatever's on the street, right? Whatever you can get. And so a lot of times we see with the opiates and other ones, and with the trauma survivors, that they'll use substances just to try to recharge themselves, just to get the endorphin boost. Of course, the dissociation works for them. When we deal with traumatic memories, maybe we'll talk about that a little later. That's a story unto itself. So if we think about this now, and we talk about physiology, we can look at things like endorphins and cortisol and see how they change over time, and with that, what types of self-medication strategies people might use. So it's one of those things that I think, if we look back at it, it's kind of a good to know and something good to watch out for. The other thing that when you in chronic dissociation is you tend to see a lot of loneliness. Loneliness has been something that I've just started speaking about because it's so, I mean, we have more people who are lonely, you know. People can be lonely in a crowd, you know, and loneliness has a lot of physical effects. So when we look at all of this, we can see these changes over time and what they bring with it. Because if I can't deal with my own pain through my own endorphin system, and if I'm trying to recover or in early recovery, and because of my lack of endorphins, I'm having difficulty with not only just what we call physical pain, but psychic pain too, psychological pain. You know, your brain handles emotional pain and physical pain the same way. It's same brain circuits. So looking at this, that's kind of what we would see. Now, if we go a step further and we look at that second leg, we just talked about the physiological stuff. Let's talk about the second leg, self and identity. And the insecure attachment style, we've talked about it, it's disorganized. When you start to look at that, it sometimes has certain themes that I notice in this population. Generally, again, this would be more your borderline trait, borderline personality disorder. One of their themes is a helplessness, and they can be very good at it. We talked about abandonment. You know, they're very into things of being a failure, of being dejected, but this whole helplessness piece is kind of interesting. And then, well, we did this yesterday. Remember we talked about abandonment fears? That some of the people, because of their early life experiences, see you as another parent that is leaving me. Remember when we talked about that, or maybe not, I don't know. But, you know, what happens, you have trauma history, you probably have attachment problems, which can feed into abandonment fears, which increases impulsivity and leads to things like substance use and self-injurious behaviors. See, what the cutting does, for example, is cause an endorphin increase. It gives you a better feeling. So when we look at this, and we start to look at self and identity, another theme is a kind of a coercive theme that kind of reminds me in Glenn Close and Fatal Attraction, but never seen one come up out of the bathtub like that, but wouldn't put it past them, type of patient. And they're very rejecting, They can be hostile and intrusive. But this one also tends to be the one that if you have a staff member who's going through a tough time in their relationship, sometimes we've had a therapist or others who've had a little fling with this type of patient, and they do kiss and tell. Of course, that's a gross violation of program rules to begin with. But, they do, I see these themes quite a lot. Now, if you look at a traumatic event, and let's just talk about consciousness now, dissociation, if you will. And if you look at a traumatic event, over time, the first thing about the trauma is that you store things often in fragments. The memory itself is not often not very coherent. It tends to the explicit stuff, the story, will tend to go away, but the implicit, all the things that respond to the triggers and cues, is very, very active. So when we look at this and we start to talk about dissociation, what we say is in a traumatic event, that over time there's a portion of memory that is erased, or we do not no longer have access to it. We forget the details, but still maintain the emotional reaction. The imprint is divided into two separate paths. The brain dissociates the explicit memory of a negative event from the emotional response. It splits it away. This is pretty brand new. It just came out. Over time, you forget the words, the explicit trace, but that emotional, implicit response is still there. So the brain dissociates the explicit memory of a negative event from the emotional response. And one of the things that makes a lot of sense to me is the sensory motor approaches, working through the body, working through the senses, is another way that we can approach things like this. So if we look at consciousness, the uncontrolled emotional response linked to the negative event is generated without knowing what causes it all the time. So when we look at this, dissociation is something that we see a lot of in the work we do. And in these situations, I think that a person's inability to recall or to come up with exactly what happened, especially if they were very early. I've done work with people who were traumatized before the age of 2, 3, and they were nonverbal. And I had them in trauma group, and I met with this lady individually. I just, she wasn't fitting in the group very well. And what I was trying to understand was sort of the way she felt about what went on, and the things that she's noticed that have impaired or caused problems in her life. And I think that in talking to someone like that, you can use little triggers like, let's draw a picture of your house. Where's your parents' room? Where's your room? In other words, you're kind of regressing them. Anything, you can guess anybody with just about anything. Now you got to just say, when was the last time you saw a pen like this? So you got to go backwards to get it. So if I'm looking at this, I think that dissociation is really a good skill if you can master it. It's a beautiful self-regulation skill. It's parasympathetic, which we want, calms us down, and I think that these sorts of things can also be helpful. Now, if we go a little further with this, to me, and we've talked about it, trust, the predictability, we've talked about a lot. Let's just look at it, in a few different ways in terms of early recovery, stabilization, the social alienation, the loneliness. You see, sometimes you'll have people who are introverts like me, and introverts look inside of themselves for healing. Extroverts look outside of themselves for healing. Extroverts love groups and things like that. Introverts will tend to spend time with themselves trying to digest what has happened. It's a different model, but if you look at this, something that will reduce the loneliness, reduce the alienation, and give them support in their recovery, and the ability to engage in competent social relationships is an important prognostic variable. I mentioned it a couple times, working with moral injury, with veterans, and with others. One of the things that I need to see is the ability for them and their willingness to reintegrate back into family and community, because without the love and support, the spirit of the community, you're out there all by yourself, and that doesn't work very well. The other thing that I want people to do very early on is get into self-care. Take care of yourself. I want you, when you look in the mirror, to like what you see. I think it's easier to believe in a benevolent creator, when you like what you see in the mirror. So if we look at this, there's just a few things. I mentioned being predictable so that we could gain trust. Now, sometimes you do assessments on people. And when you think about the history of assessments, I might ask them a question. Have you ever been in a diagnostic interview like this before? See, a lot of people have been through a number of these in different systems, and they've usually had some not so positive experiences doing it. And so what I want to know is what I'm going to run into here, because they're carrying all those resentments and everything else right into the room, and I'm going to be the target. So I ask them about their past history of assessment. Have you ever been assessed before? If they say no, I just explain to them a little bit about what we're doing, how I want you to ask questions. Anytime you want, you can stop me. I say, look, when we finish, I've got to write this report up. I don't care. You can read it if you want. See if you agree with it. So in looking at this, if they say yes, then I want to ask them, tell me about that experience. Well, before I knew it, they had me in a psych unit, took off all my clothes, gave me this darn little gown that when my butt's hanging out the back, and put me in this locked unit, and they just didn't tell me anything. They weren't very nice to me. I couldn't get my questions answered. It was an absolutely miserable experience. If I ever see that guy again, I'm going to punch his lights out. Well, what do you say to that? This session will be nothing like that session. They've already told you what you needed to know. We're going to take our time. I want you to ask me all the questions you'd like. You can read this if you want. So what I'm telling them to try to reduce some of the angst. Because see, this is coming in there with them. I need to put that to sleep a little bit. And so I'll acknowledge it, and we'll talk through it, and I'll tell them what I'm going to do is be very different. And all the things that were a problem in that other assessment, I'm going to tell them that this is how we're going to run the assessment. We're going to take our time. We're going to answer questions. All of these things we can do. And so the first thing is that in this past history of assessment, if they've had negative experiences, I'd like to clean the slate a little bit, and this sometimes is helpful. In relationships, we get into a lot of issues. I just show you how some of this happens. This was a lady, her name was Marcia. Marcia drank quite a bit. She was 35, one of the brightest people I've ever met. She was, at 35, was vice president at AT&T and upwardly mobile, and she was good. She dressed the part. She could speak the part. She deported herself in those ways. So, what happened was when she got promoted to vice president, her reporting relationships changed. And so what happened was she now had a senior VP, and this was a female. Before, she'd always reported to males, and it always worked pretty well. But it seems like her chief complaint when she came to me was that I have a senior VP that supervises me, and we can't get along. We butt heads on everything. I need to make a decision. Should I stay at ATT and try to work through this, or should I find another company that will allow me to meet my goals? I mean, she wanted to run the joint, and I think she probably could have done a good job. But what happens in this, when you looked at Marcia's story, and let me kind of tell you how that worked. It was pretty interesting to me. Marcia is a workaholic, and she liked late evening, as late as I would go, usually 8, 9 o'clock appointments. And one night, she kind of came in, and I could tell there was something kind of going on with her, a little different, and I just started to talk to her, and I tried to be soothing, and I found out what was going on, and she looked at me and she yelled at me, and she said, "You're not listening to me." Well, her body was speaking pretty loudly. I did blow that. And what had happened to Marcia was when she was small, her father used to sexually abuse her. And he would make his wife, the mother, stand in the room and watch. And so Mom is standing over by the door, rigid as can be, apparently, and Dad is, doing this to Marcia. And so the interesting issue with this was that when you looked at this, you had Dad here, and you had Mom, and she was angry at Mom. He's the perpetrator, but Dad could show affection. Dad, could be a pretty nice guy sometimes. But Mom, the reason she was angry at Mom was Mom didn't protect me. I went to my mother and I told her what was going on, and she said to me, "No, that doesn't happen in our family." And so when you look at this, what was happening with this female senior VP was the whole dynamic playing out of that anger towards Mom, and this relationship was just not working out very well. And so it's one of these things that you kind of run into with some of these types of individuals. Now, any questions that you might have? Anything you want to kick around for a few minutes? Why don't we do this? Let's go about 10 more minutes, and then we'll... Yes, sir. What was that? I'm sorry.
On your patients, when do you determine when they're acute or chronic?
Acute or chronic?
Yeah. Acute,
well,
chronic,
mm-hmm.
lifetime,
Sure.
How do you make that determination?
Well, in a chronic disease, sort of like my rheumatoid arthritis, I was diagnosed at around age 50. I had my first big nasty flare-up last fall, and it just, it laid me out. And, what had happened in that was I'd gone from an acute problem to a chronic problem. I have to live with this every day now. We look at for example, an addiction. There's the acute sort of early use, and then as one progresses, they develop this chronic illness that we like to treat in an acute care model, and it doesn't work very well, does it? But yeah, it's you look at, it's not necessarily duration, it's looking at the disease itself. And
how do you determine addiction from on your chronic patients?
Addiction from...
If they have arthritis, they have to take, they have to have pain management. How do you determine if they're, it's an addiction problem?
Well, you're talking about someone with a pain problem that's been medicated with opiates? What was it about that? I missed it.
You know, like if how do you determine if they're, you know, they're have addiction problem when
If they have an addiction problem, okay. Yeah, I'll do my best with it. One of the things I think we have to make is a distinction between dependence and addiction. You see, if I was given pain meds, that wouldn't be a good thing for me. You know, it would cause a lot of problems. Pain medicines change your brain so quick. I mean, it's amazing what they can do. But you see, dependence, if the doctor orders me to take 3 tabs every day, and I take 3 tabs every day, like the doctor prescribes, I will be dependent on that drug, physically dependent on it. But what separates out addiction is the escalating use, the escalation of use, and the consequences. So what we have, and you can top it off with drug seeking. In addiction, you have a person who is drug seeking, and they're looking at drugs from multiple sources to get their needs met. This is why it's so important to do the urinalysis and to really check these things out. But you know, this is a problem area for us right now. You know, buprenorphine or Suboxone is a pretty good painkiller, but you have to take it differently. It's long-acting for you know, your addiction, but short-acting for pain. So if you were on 16 milligrams, which is a common dose, what we'd do is break it into 4 milligram doses, and every 4 hours, you know, or so, you take you know, one of those little pieces under your tongue, and it can be a decent painkiller, and it's something we use with people in recovery. But sometimes you're just going to have to be on painkillers because you can't function without them. You see, I don't have a real problem with that. The problem I have is what it's going to do to the patient's brain, and are we going to get into situations where, you know, it's going to lead them into a relapse. But, you know, if they can do this, which their history tells us they can't, then that's a wonderful thing. But what we'll generally see is, you know, thinking like an addict, if 1 is good, 4 must be a lot better, you know. And so you got a bottle of 60 pills and they're gone in 2 days, you know. They're tough on the refills these days, that's for sure. You know what's happened in this area with pain? The regulations that they put into place are killing a lot of people. We have chronic pain patients who can no longer get pain meds, and we're seeing a lot of suicides, or we're seeing them go out in the street and try to buy something in the street to ease their pain. But I'll tell you, you know, I understand that we need to restrict things. I understand that pharmaceutical companies and physicians need to be held accountable. But to blame pharmaceutical companies and physicians for the opiate epidemic is about 180 degrees off base. It's not true. I showed you yesterday that prescriptions have gone down 30%, but overdose rates going crazy. And then we looked at the fact that in 2010, we switched the OxyContin products from the OCs to the OPs, and yesterday I said that when you try to crush this one up, it just mushes up. You can't work it into a solution, you can inject it. We talked about Iroid yesterday, and you know, what do you bake it in a microwave for at some temperature for a period of time, and then you freeze it, and supposedly that's going to work. I don't know. I don't have that kind of faith in it. But you know what happened was several things. With the OPs, it was no longer a great attraction to people who inject, because you couldn't inject them. Plus, it was so darn expensive on the street. This stuff was going for at least $1 a milligram. If you got a 40 milligram OxyContin, you probably pay 40 plus bucks for it, whatever the street economy is involved in, but whatever price it sets. But when you looked at 2010, that's when this change happened, when we switched from OC to OP. And so from 2010 on, in terms of opiate prescriptions for pain and other things, it has gone downhill. And again, if we have unscrupulous doctors or pharmaceutical companies, they need to be held accountable. But, you know, today with the pharmacy management system, do you have a pharmacy management system where a doctor can go on and see all your scheduled drugs that you've taken, all your drugs that you've been taking? In Florida and many states now, there's a system that any physician can go into and immediately get your prescription track record and see what you've been using. Now, if you look at this, right around 2011, right in here, 2010, 2011, what we started seeing was heroin taking off, cheap, very pure, or a high degree of purity, and very available, and it works. So what happened was there was a switch over to heroin, followed a year later by a switch into fentanyl. And right now, the opiate epidemic is driven by these two drugs. And that explains why, even though opiate prescriptions have gone down 30% plus, the overdose rate continues to go up, you know. And so this was an unintended consequence of switching the formulation, but these things happen. For example, you know, when they caught that guy coming across the border with 500,000 Sudafeds for personal use, you know, people got kind of interested in Sudafed, and because it was one of the chemicals you could make meth from, and so they started to restrict Sudafed. And so what happened was the cartels actually came up with a less expensive way of making meth that also created greater purity in the product. So it didn't work out quite the way we wanted it to, but you know, those things happen. So if we look at something like this, and remember what we said about opiates with trauma survivors, the dissociation, the dopamine, you know, the endorphins make you feel warm, fed, cared for, the things you didn't get growing up maybe. So as we consider these things and what kind of goes on, let's kind of keep going with some of this information. We'll take a break here in just a minute. Validating people's feelings, entering their map of the world. You see, for trauma survivors, their worldview is very concrete and restricted. You know, the world is unfair. Everything is unfair. You know. Pardon? Right. There you go. There you go. So if we start to look at this, one of the people that I felt really helped me out over the years was Milton Erickson. I told you a little bit about it yesterday, and what he said about entering the patient's map of the world, understanding who the patient is. That's where the open-ended questions come in, some of the MI, motivational interviewing things. But what I want to do is I need to find out what their map of the world is, because treatment has to start where they are, not where I think they should be. And I also mentioned that you always treatment plan from strength, never from weakness, unless you want to set them up to fail. And this is what Milton taught me. I sort of like have a little Milton that sits here and whispers in my ear sometimes. But you know, this whole view of the world has changed. The world is unfair. You can start to see where some cognitive therapy might be helpful, because you get into those sort of statements of always, never, types of automatic types of responses, and it kind of fits into this fairly well. Now, if you look at trust and predictability, safety again, let's just talk about patients coming in for treatment who have a history of trauma. I don't have a lot of patients that come to me and open up with trauma. Most of them come because their drinking and drugging is out of control. Their relationships are just as wacky as can be. They're depressed and wondering if life is worth living. They come in because they're having difficulty in raising children. These tend to be often the presenting problems. And, when you start to look at this, if I have someone who is presenting in full-blown PTSD symptoms, well, I'll give you an example. I had a lady that, as I told you, I live outside of Orlando, Florida. A lady was referred to me from a psychologist in Tallahassee. And the lady was moving, whole family was moving into the area because her husband got a new job. And this lady was involved in a large extended Italian family. She'd never been away from home, and she had a wonderful support system at home. So what happens is that, she leaves and she comes up to Orlando, and it's a lot of pressure on her. So she starts to have the nightmares. And when she came to see me, she stopped right in the door. And before she even walked the door, she said, "Dr. Knuckles, I need to know if it happened." She said, "We're in our cabin up in New England, and I hear my sister scream. And I say, I got to help my sister. And so I go to the top of the steps, and I look down, and there's my father on top of my sister, and my mother standing over in the corner. And I say to myself, I've got to help my sister, but my legs won't move. And all of a sudden, my father looked at me only in the way he could look at me and said, "You're next. Did it happen?" Well, you don't get a lot of those, but with something like that, they need. If they're having that much of a problem, we want to be directive as therapists. We want to take control. They're looking for somebody to take control, and so come on in, sit down. Let's see what we can do with this. And the problem with her was that she just didn't have a support system, so we had to get some people to kind of stay with her. But, we look at stabilization, validating feelings we've talked about. I think we've kind of gone through the best part of these things up to date. But again, by understanding what has changed, it gives me an idea of what I need to stabilize. We had a bunch of vets, 250,000, march down Michigan Avenue when I lived in Chicago. We had all sorts of problems after that, because they're back in the same old talk. They're talking about the abbreviated names for all the guns and things that go boom, and they're getting off on all of that, and the camaraderie of it and the memories that are brought back. And we had people who were just struggling for a good while after that. But you see, in that case, you had something that was an event. It's over and done with. I can stabilize this person. Their symptoms will probably get better. They really need further work, but sometimes if I can get them to do that, that's wonderful. But, usually we can get the symptoms under control. The other thing I found with this population is that don't use open-ended contracts. If they say to you, how long is this going to take? How long is therapy going to take? My answer to that is kind of, who knows? It's really going to depend on you and how you work and how things proceed. And if you're satisfied with what's going on in here, if you feel like you're making some movement, it take whatever time that it takes. And I can't really tell you exactly what that's going to be. But, what I do with them is a closed contract instead of a kind of an open-ended one, where we leave it open like that, nebulous. That creates a little anxiety. So what I'll do is I'll go to a closed-ended contract, and I'll say, right now, let's contract for whatever I can get. 3 sessions, 5 sessions, whatever I can get. And at the end of those sessions, let's sit down and talk about where we are and what we're going to do going forward, you know. And what I find with that is that they're more likely to come to, if they have a contract that is, yeah, I'm going to come to 5 and then we're going to evaluate it, they'll tend to come to those 5. You know, they'll tend to be pretty compliant, but if you leave it open-ended, you're just going to find out they just didn't show up, you know, they just gone. So my sense is that that closed contract gives them some set of boundaries, some set of limits. They kind of can deal with that. It doesn't cause any anxiety. Plus, it gives me that shot. You know, I want that one shot. If they're thinking about dropping out of treatment, I want that one shot at them to try to keep them in treatment and keep them moving. Now, if we looked at just treating PTSD, there's all sorts of different models for this. We'll kind of talk through some of them, but I think, what time is it? It's a little after 3. Why don't we do this? Let's take a break, and we come back. We'll talk a little bit more, and then what we're going to do is we're going to have the real experts come up and speak with you. All right? Let's take a break. kind of the essence for some of you, and some of you have some long drives. And what I'm going to do, the pieces that I talked about in terms of the treatment, pretty self-evident. It may be that at another time we might just do a day on trauma or a day on suicide or something like that, so we can really get into it in a little more depth. But again, if you have any questions, email me. If you want any of the PowerPoints, please let me know. I'm happy to give it to you. I just want to tell you that I love you, and I appreciate the fact that you gave up your time to be here, and because that's a big commitment. And some of you came from some pretty long distances, and I'm very appreciative of that. And I thank you all. I hope you're going home today in your car that's paid for to your home that's paid for. How about that? Might as well hallucinate a little bit, huh? I'm going to turn it over to Ed here, and Ed's going to be the master of ceremonies, I think, for our panel. Got you guys?
So we have a panel we've assembled, and we're going to give these guys about 2 hours each to tell their story. Gee, I didn't even get a smile. Look at this, man. That hurt, didn't it? No, they're all three of them are in varying stages of successful recovery. So what we wanted to do was give them a few minutes to briefly highlight their journey, and then we wanted to open it up for questions. So here are the true experts. They are it from the perspective of somebody that's been there and done that. So if you've ever, anything that you ever wanted to ask of a meth opioid addict, now's the time. So with that, I think I'm going to let them introduce themselves, and we'll just let them share, and then I'll facilitate the question and answer. So, has anybody? Have some of you got questions already? Anybody? Well, this ought to be fairly short, huh? Who wants to go first?
I'm just kidding. Hello, my name is David Mills. I'm Ogallala Lakota from Pine Ridge, South Dakota. Just kind of share a little bit about my story and where I grew up and where I'm at today. I was born in Pine Ridge. I ended up moving to different places, but I ended up in Atlanta, Georgia. There, at the age of 16, I was on my own, living on the streets. doing heroin. Started off with pills, or drinking, smoking weed, then doing pills, and then heroin. And it led me to injection. I was IV using, and living the street life. I've seen darkness. I walked through it. I've been to hell. And when I came back here for treatment. And I did go to treatment, and it was okay for a while. But circumstances changed after my father committed suicide. I went right back to my old lifestyle, selling drugs, fighting, robbing, just living a dark life. And it was soon where I was back to doing heroin, and then I was introduced to methamphetamines. Right away, methamphetamines took my life over. I lost everything. I had a home, I had a family, I had my daughter, my youngest, and everything. It took everything from me. I was homeless. I don't know how many times I've been to jail. I got locked up several times. And, you know, for me, it was just, I thought I was gonna die that way. I accepted it. I was told by a counselor before that I was dead on the inside. I was just waiting for that physical bullet, which was true because I didn't care what happened to me. I just wanted to continue my addiction. And, you know, I was selfish. I was a very selfish person back then. But while I went to jail, I got arrested, and I'm a felon. I should have went to prison. I still think to this day I should have went to prison. But the first time, the Creator blessed me and gave me an opportunity, and I messed that up. And then He gave me another one. I messed it up again. And that's when I was at the point where, you know, it's time. I know I'm going. And that judge, I don't know, the Creator worked through that judge, and that judge looked at me, and she saw something in me when I didn't see anything. I was hopeless, and I got the opportunity, and I was blessed to go to the methamphetamine program here in Rosebud, and I can honestly say it saved my life. I learned so much about myself, you know, all the different personalities I had adapted to change and to get what I wanted, to pretend and act. And I got to learn about all the thinking errors and all the mental illnesses. I was diagnosed with bipolar depression, and you know, working on that, I have I'm no longer, well, I have depression. It's no longer major depression, and bipolar depression is just depression. And I'm grateful the Creator blessed me with the opportunity. But coming to this treatment, it was a blessing in disguise. For so long, I thought that the Creator hated me, that I was being picked on, or I'd got dealt a bad hand of cards. But it wasn't that. It was just, you know, he was answering my prayers, just not in the way I wanted Him to. And but coming to the treatment, man, it saved my life. It gave me the opportunity to get rid of things, and I went through some stuff. I'm not even gonna lie, I almost got kicked out of the treatment twice, and you know, they continued to give me a chance. And honestly, without the program and without them committed to helping me, I would probably be dead right now. I've been to institutions, I've been to jail. My next step was death. And so I'm very blessed to be here today. The Creator has helped me in so many different ways with basically a second chance at life. It literally is a second chance at life. I'm doing really good right now. I'm going to meetings as much as I can. I'm working full time. I'm going back to school this fall semester, and so I'm very grateful for this program. It taught me how to live again, how to be a human being, and how to be independent, and how to be a father. That was something that I had no idea how to be. I have 2 daughters, and I didn't know how to be a father a year ago. And today I'm able to do those things, and it's all because of the program. I was there for 13 months and 13 days, and I graduated in February. And my life, the recovery has been amazing. The best part of my life is while I've been sober. And when I look back at my life, I regret nothing because it's made me into the man I am today. But thank you for allowing me to share.
Thanks, David. Hello, my name is Gifford Standing, and I'm an addict alcoholic. I am from the Fort Peck Assiniboine Sioux Reservation in Montana, northeast Montana. I grew up in a little small community outside of Wolf Point called Oswego. I grew up in a household with an alcoholic addicted father. My mother was a workaholic. I had two younger sisters. Some of my earliest memories growing up were tiptoeing around my dad when he was coming down, when he was crashing, and creating diversion so his form of discipline didn't come down to my little sisters. So I'd take that. I grew up not being able to make mistakes for fear of being called a little asshole, being told, get out of the way, you're just in the way, move, go on, get. Having those things said to me at such a young age, and remembering those and growing up, I never felt like I belonged, I never felt wanted, I knew I was cared for. We never wanted for anything in the house. My mom made sure of that. But as I started getting in my teenage years, I was popular, I was good in sports, I had a lot of things going for me, but I still felt empty, worthless, like I didn't belong. I felt unloved and unwanted. Until when I was 15, I discovered alcohol and marijuana. From that point on, I started my love relationship with mood-altering chemicals, and it progressed. By the time I was 17, I'm in high school, and the only time I could control my alcoholism was when sports were going on. I could stay in school long enough and function well enough and I'd stay sober, so I was motivated there, but as soon as sports ended, boom, I was back to drinking, doing drugs. Graduated by the skin of my teeth and went to college and found out that I fit in a party crowd still, using drugs the whole time, and I got introduced to harder drugs, cocaine, ecstasy, tried everything I could get my hands on, and I felt that love. Going through life, I ended up discovering methamphetamine in my late 20s. I was 26, 27. With that going on, I decided to make the choice to walk out on my family. I walked out on my son and his mother. And I had a love affair with meth until I discovered OxyContin. OxyContin took it to a whole new level, and I felt that wave go through me. It was warmth, it was love, it was acceptance, it was everything that I was looking for. So I kind of cheated on my meth addiction with OxyContin. And as the time grew, it got worse and worse. I kept destroying people's lives as I walked into them, and I'd walk out, and in my sick mind, I'm thinking, boy, because as I destroyed their life and made their life worse with my toxicity, I was thinking, man, I avoided a wreck there, when the whole time I was the wreck. And I was literally a tornado in a trailer park, just leaving nothing but devastation behind me, and I didn't care. It was all about me. I'm selfish, self-centered, egotistical. People were objects. What conscience I had was killed off. I was detached until I got 38. The Creator decided he finally had enough of me trying to kill myself. When I was 38, my lowest point was when I was homeless. I woke up in an alley in the middle of winter in Wolf Point, and northeast Montana winters are kind of rough, harsh. And I wanted to die. I didn't want to live. I was hopeless, and I didn't have anywhere to go. I didn't want to be anywhere. I curled up in an alley by a dumpster, and I said my goodbyes to myself. I had no spirituality, no belief in anything, and I wanted to die. I was hoping that I would not wake up. The next morning, around 4:30 in the morning, I woke up covered in snow, and I was angry. I didn't know who to be angry at, but I was angry I was alive. I wished I was dead at that point, and I couldn't kill myself. May 1st, 2016, the Creator blessed me with sending me to jail. I got a harsh sentence for a petty crime. I mean, it was simple assault, but it was a misdemeanor on my reservation, and I got a hard sentence. I got like way more than maxed out, and 60 days for that was pretty harsh for us, and something happened when I was in there. I got clean, I got dried out, and people came into my life, it was just like, I can't explain it other than it was just the Creator. I know it was the Creator putting these people in my life to show me that there's a different way. And I got curious, and towards the end of my sentence, I didn't want to get out. I felt safe in there. It was just totally safe, and I felt free. I felt free. As twisted as that sounds, being locked up, I felt free. I fought to stay in jail another 31 days. I had my parents involuntary commit me, and the judge wouldn't keep me without me getting a new charge. So I was willing to go I was going to violate my probation. I was going to walk into a bar just to get another charge to go sit back in jail because, and like I told the judge that day, I had something I never had before in my life since I was 15. And she said, "What's that?" I said, "I'm clean and sober for 60 days right now. Don't turn me loose, keep me." And I did. When I got out and I had started the process to come to treatment, I heard about Rosebud. I heard about this long-term place, and I needed a way to get out. At this point, I wanted to live, and I seen that there was a better way, and it was tough. I stayed 2.5 months clean after that, so I had a total of 5.5 months clean by the time a bed date came available, and it was hard. It was chaos. It was craziness, insanity going on in here, and I knew things weren't right. By the time I got accepted in treatment, I came, and in there, I learned to accept that I wasn't perfect. I learned to realize that I'm very deeply flawed. I learned that having feelings and having emotions and experiencing them and allowing them to happen for me is a blessing. They're given by the Creator. They're not a weakness, they're strength. And through the program and great people that I've met in the program that I'm still very much grateful to be a part of now to this day, I learned how to live in a good way, a clean way. And to this day, I'm clean and sober, over 3 years now, and each day gets better and better. And even on my worst day now, it's still better than what I thought was my best day in my active addiction. And I'm grateful, and I thank you all for listening. With that, I'll pass.
Good afternoon, everyone. My name's Wambly Meter. I come from Eagle Beach, South Dakota, Cheyenne River Reservation. Long story short, grew up in a single parent home. My mother was always working, trying to provide for us. My father was battling alcoholism. He was in and out of my life, first 14 years of my life. So my mom sobered up and worked for us, got a good degree, whatnot. But we still had the family roles, and I took the role on as the hero. Always wanting to be perfect. I didn't want her to have to worry about anything, so I helped out as much as I could and excelled in school, good grades, honor student, whatever I could do to be the people pleaser, to continue to make our family look good in the outside world. But we grew up with an abusive aunt, so there was always the getting in trouble and being punished and whatnot. And we finally got our own home. We moved on, and I continued with helping out, taking care of my siblings, and doing what I could. And after a while, the anxiety, the stress took over. 17 years old, started experimenting with alcohol, marijuana, and it continued on throughout the rest of my life. And it got harsher and harsher. And I passed that on to my children as I was a functioning addict, have a job, do it in closed doors, trying to keep the outside world at bay, letting them know that everything's okay. And that continued on for a very long time. It led from alcohol, marijuana, prescription pills. There's a lot of low points throughout my life. They were never addressed. No one ever told me I had a problem. No one ever told me I should probably seek help. I think there was a suicide attempt that went unlooked at. Found myself taking 32 tramadols in one day, had a seizure, woke up in the hospital. The doctors and nurses said I was allergic to tramadol. Left it unlooked and I was sent home. Continued on. My spouse at the time got herself in some serious trouble and ended up incarcerated. We had 3 children and I was a single parent. But rather than seek help, I tried to do it on my own. Tried out on my own, got a job, and there was never no healing, there was never no tools or proper knowledge of what addiction really was. So it only lasted for about 18 months. Had a job, functioned right, and then fell back into it, and then came across methamphetamine in 2014, July, 3rd week of July 2014. And it was a hustle game. It was a way to make money, but also as a way to take care of all of the mental aspects of everything that was going on around me. And at the time, all throughout my life, the addictions, I never considered that the harm that I was causing my children, my family, my loved ones, like Gifford said, all about me, all about what I was doing. I didn't see myself harming my children because in my eyes, I was providing for them. They had materialistic things. They didn't have values. They didn't have a right way to live, but I could provide materialistically, and in my eyes, that was good enough. And as time went on, more trouble. And as David said, jails, institutions, and death. I was in jail. I was thankful and grateful enough to be accepted into the Rosebud treatment program here, and I don't want to say test run, but when we got there, there was no one there. There was nobody there for us to gauge ourselves on. So we were kind of learning on the fly, and it took a long time for me to want to change my ways. I almost chose prison over coming to treatment. The only reason why I sat there in the courtroom probably for about 5 minutes, my lawyer looking at me, what do you want to do? And in my eyes, I didn't want to change. Prison seemed a lot faster way of getting out than going to treatment. The only thing that stopped me from making that decision was my children were in the courtroom, and my children were always there. So I decided, let's do treatment. Got the treatment, still didn't want to accept the program. The program wasn't what I wanted. I was just looking for a way out. And it took 3 months. It took 3 months for anything to start to compute, anything to start to make sense, because I didn't want to accept it. And as time went on, as you learn to empty the trash cans, the shame, the guilt, the letting go of resentments, the forgiving, the finding spirituality, it all comes together. It all makes sense, but you gotta really, really want it. And it's been a life-saving journey and a really eye-opening journey. You don't view the world the way you used to. There's hardships, there's always gonna be hardships, there's always gonna be bad times, but you learn that attitude of gratitude and you continue to find things to be grateful for, to be alive, to be sober, to be a father, to be able to gain trust back, to be able to accept things the way they are. There's too many things in this world for us to be lost in addiction, and it's just a really good journey to be on. And if it wasn't for Rosebud, Ed, the counselors, everyone else I came in contact with, I don't think I would be here right now. And I'm really thankful for that. Thank you.
Some remarkable stories. Tell you what fascinates me most is these guys completed treatment and they didn't relapse. We got 3 years of sobriety from meth without going back to using meth, and then 2 and then 1. Treatment works. It works. But the central theme is they all found their spirituality there. And that's where it's at. That's when the lights come on spiritually, that's where it's at. And they found that in the treatment program. Questions? Anybody?
What was it? Someone new in recovery? Could you say it again?
Advice for somebody new in recovery.
Find a strong support group. Find people that are going in the same direction that you're going. The lifestyle that you're living is going to allow you to open up to others, but you got to find the right people, and they're out there. Something that we deal with as addicts and whatnot is we make excuses. We make excuses to go the other way. Finding a strong support group is key to continuing your recovery in a good way.
Anybody else? Yes. What are you doing to maintain your sobriety and staying in recovery?
Well, for me personally, I'm fortunate enough to work at the meth treatment program. I go to school, I fill my time up as much as I can. I hang around clean and sober people. I go to meetings when I can fit them in, but if I can't fit a meeting and I'm still in contact with a spiritual advisor, a couple different people that act as sponsors, and I got a strong support group. Like us in recovery, we have a tendency to always want to think we're alone and feel like we're alone. I personally have a hard time reaching out asking for help, and the Creator, I mean prayer, having a belief system, that is huge. That's key. The foundation in recovery, spirituality, and if you're going in that direction, the Creator provides what you need, and the people that He's provided for me in my life that surround me, that's my strength. Me, I am weak. I'm very vulnerable. I have a tendency to just be unhealthy if I don't take care of it. It's self-maintenance, and my friends, my family, my loved ones, they got placed in my life for a reason, and they give me the strength that I need to stay sober just for today. I don't got to worry about yesterday. That's gone. Tomorrow is never here. If I could stay sober right now, I'm good. But the people around me are what help me. This saying was always said to me when I was a kid growing up, when I was partying, and my grandpa, rest his soul, he always said this to me because he knew the path I was going down, because he was a recovering alcoholic. And he'd look at me and he's like, grandson, it's hard to soar with the eagles when you're hanging with the buzzards. And I never grasped it fully until I got to treatment and I understood, change your playpens, change your playmates, and then boom, those things like that he used to tell me back then, I never paid attention to, but they mean so much for me now, and that's the Creator showing me that there's people out there that care, that's how I view it, so I'm very grateful.
Oh, the question? How we maintain?
Yep.
How we maintain. For me, I realized before I was leaving treatment, and I had to change everything about my old life, everything about myself, about who I hung out with, what I did, how I acted, what I listened to. So I changed all of it. I completely, I started going to meetings constantly as much as I could. And I was chairing the meetings, meeting a lot of good people in recovery, keeping in contact, talking to people in treatment. Met a good counselor down in Pine Ridge at Ampetaluta and stayed in contact with him, saw a counselor. I stayed on a structure, and I continue to stay on a structure. And so for me, it's every day's a challenge. It's one day at a time. You know, I'm sober today, and I'm very grateful to be alive. Spirituality is a big thing for me. I have to pray. I have to pray every day, almost all day, every day. I deal with so much emotions throughout the day, and in the past I wasn't able to deal with those emotions the right way, so that's why I use drugs. But today I'm able to pray to the Creator and remember that, you know, everything's happening for me, not to me. And so I continue just to live my day. Yeah, just, you know, sometimes I gotta live it minute by minute, but I get through it with the Creator's help.
How I actively maintain my lifestyle is I'm very family oriented. I'm actively involved in each of my children's lives now. Both of my sons are on traveling teams that I'm grateful enough to be able to coach. So we do a lot of fundraising activities and traveling. I'm allowed to be around the things that I love. I love to coach. I love to watch basketball, play basketball. Very active in my daughter's lives. My daughter just got back from Pathways to STEM in the University of Minnesota. So pushing them, being actively involved, and spirituality-wise, I love our culture. I love our ceremonies, and I sweat. I love to sing, pray. Sundance, it's all there. It's all the tools that you need. We find our own way, and spirituality-wise, it's our culture, it's our heritage, and it's a learning process. You learn something new every single day if you're open to it.
Any other questions? We had 3 young ladies also that were invited, but for whatever reason they chose not to come up and share. But one of them has almost 2 years, and then the other in lesser degrees of, but they're actively in recovery as well. Successfully completed treatment. Is that it? How many prior treatment experiences have you had?
Rosebud, the treatment program there, that was my only time in treatment. But like I said, I think throughout my life, a lot of times went overlooked. A lot of times I should have been there, but I don't want to say no one cared enough. Maybe no one wanted to speak up and tell me that I had a problem. And it took a lot of falling out on my end to finally see that I needed help. And when I got there and the tools, the knowledge that was presented to me, it helps me today. You learn to process before you make any decisions. There's a long process of what you're gonna do when you think of something. And by the time you weigh the pros and cons of your actions, you have the answer you're looking for. And it helps you to be able to move forward in a good way.
For me, there was a lot of people throughout my life tell me that I needed help. They wanted to help me. As soon as they did that, I pushed them all away. I knew best. It was me. Treatment in Rosebud, the meth treatment program there, my one and only time in treatment in the dictionary definition. Now, I'm in treatment every single day. I have a disease. It doesn't go away. It's with me all day, every day. there are things in my program that I rework multiple times every day as I feel the emotions that I ran from and hid my whole life into drugs and alcohol. So I'm still in treatment. I will be till the day my body gives out, my spirit goes on. And I'm grateful for that understanding. You know, that's not a viewpoint that I would have ever thought in a million years I'd even hear myself say. So that's a blessing right there for me.
Rosebud was my 5th treatment. I went to 3 others, 30-day treatments, and I successfully completed. Didn't keep me sober too long. And I went to another one in Rapid. I got kicked out of that one, and then I came to Rosebud. And I agree with Gifford 110%. Just because I'm no longer at the treatment facility, my treatment still, every day I live treatment.
Other questions? Yeah, why was Rosebud successful?
I believe that with meth addiction and everything that was clinically explained to us, we needed it. Your brain needs the time to heal. Your brain needs the time to be able to take in everything and learn from it. We weren't ever stuck there, like we couldn't leave, but majority of the time when it came to the choice to leave, if we wanted to, we stayed, and there was reasons for it. It was starting to make sense. Like I said, I spent the first 3 months there playing the game, and I was going to continue to play the game. And then somewhere along the way, it made sense. Emptying the garbage cans, learning from it, and dealing with it, accepting it. And once you get that feeling of knowledge, and you want more because you want understanding on why you are the way you are. And I believe Rosebud gave us that information. Rosebud showed us the way, and it showed me the way. And I couldn't give up on myself, couldn't give up on my children, and if this was a way to save my life, then I was going to stay. And it's good.
For me, it's definitely starts with the long term. Like my brother Wombly says, it takes a long time for the damage that we've caused ourselves to start to heal. That's one. But for me, on top of that, is getting to choose to pick a spiritual path to start on. That is the key for me, is the spirituality. I'm not going to say it's not anywhere else. I don't know, but I know it's here. And I know that's what it is for me, and that's what keeps me going every day. The getting to heal and adding spirituality with it, it opens up new doors for me in my brain's healing process.
I agree with these guys 100%. Long-term spirituality, the long-term helped me in so many different ways because it gave me the opportunity. I worked the 7-direction model a bunch of times, and it gave me the opportunity to really learn about myself and find out who I really was, because I had no idea. I had so many different personalities and masks that I put on. So the long term and being able to see what I was actually doing to my brain and my body, and then being able to pick what I believed in, and being taught a lot of my culture, that helped me, so much, and it showed me the path that was that Creator had created for me, my purpose. So, yeah.
We have a 7-direction model, but he's saying it was a 843 direction.
Oh, I'm sorry. It's, I don't want to sound mean, but it's hard to change your circle and to see your family, your loved ones, good people that you used to know, still lost in addiction, but we've all been down that road ourselves, and in order for them to want to heal, they got to want it first. And if they're not on that right path that we are, if they're not going in the same direction we are, that different people, places, and things that comes into play. And you can tell them everything that you've learned, but if they're not willing to accept it, then they're going to continue on the way they are. That's going to create toxicity in your life, and you got to learn to be able to take a step back. That's still your family, that's still your loved one, that's still your friend, but until they want something better, it's their journey, just like our journey is our journey. And as hard as it is to see people struggle like that, because I've struggled like that, it's always going to be their journey. It's always going to be their choice. You wish them the best, you pray for them, but when they're ready, they'll be ready.
Yeah, there's when I didn't go back to my home for a year and a half, and when I first did, I was so excited to see, even though they're still out there lost in their addiction, they're doing what they're doing, I just wanted to see some of my close family and tell them I love them and I missed them, and to this day, most of them avoid me. They pass judgment. They come at me, and all I can do is pray for them. I love them. I don't love them any less. I pray for them, and is it sad? It's sad to see. It's very sad, but I'm not willing to jeopardize my sobriety, my clean time, to go out of my way to incorporate people that are living in a toxic lifestyle into my life. I don't have time for that. I worked very hard at trying to kill myself, and now I got to work even that much harder to live each day. And that's something I'm not gonna, like I said, their family, I love them, but I'm not gonna include them if they're toxic. And I pray for them, and I hope they change, and if they want to talk, I'm always there. I'm never gonna turn them away. But at the same time, I'll try to reach out to them, and if they don't reach back, hey, that's on them. I got to go forward with the Creator. He's leading me, and I'm following, and I'm along for the ride, and I'm grateful to be along for the ride. There was a time when I was 26 years old, I was in a car wreck, and I died. It was alcohol, drug related. I died, and in that, I had a spiritual experience in that, and I seen where I was going, and in my sick, twisted mind, I took that in all the most worst ways you could. I seen it as why I didn't even the thought of changing so anything different could happen, because I had a hard time believing it. I denied that even existed until I got to treatment and lights came on and spirituality happened. That memory came flooding back, and it was like, wow, I was really, really sick and toxic, and that time in treatment I was still really sick and toxic, and that sick and toxicness is still in me, and I recognize it in my family members, so I just don't welcome it back in my life, but I still want the best for them. I want the best for everybody. There's hope out there, and I hope they find it. I hope they accept it. It's there. So I'm just grateful to be here today.
For me, I'm like very protective over my recovery. So I set up a lot of healthy boundaries, and I changed my friends that I used to hang out with. I don't hang out with. I do have family members that drink and smoke and do that stuff, but I don't go out. For me, if I see you in person and you're my family, I'll tell you I love you and how are you doing, keep a conversation, but I won't go anywhere. It's for my safety, and I do that with everybody. But I try not to communicate with anybody that's using unless they need somebody to talk to, unless they're ready to or ask for help, because my recovery is very important to me. I want to live. And so, I love my family to death, and there's some friends that I still communicate to that are like brothers to me, but I want to protect my recovery because I don't want to die. I have children, and I just set up, healthy boundaries.
Truth be told, I was just talking with Kip about this last night. The cravings aren't so intense now, but as an addict, you entertain the idea of maybe I can this one time. I should probably go out and have a few with some friends, and you entertain the idea. And then you go to what you've learned in treatment, and you go down the line of your coping skills. You weigh your pros and your cons, and you think long and hard about the decision you're about to make, and when you come down to the end of it, everything's gone. It's not as important as you made it out to be. It's not something you can't handle. It's not something that I'm gonna throw everything away because I just wanna enjoy myself, because there's other ways for us to enjoy ourselves now. We don't need to medicate. We don't need to run away anymore. We learn to face things head on, take them as they are, but like I said, as an addict, you entertain, you think, and you decide, you weigh, and when it's all said and done, you know why you're where you're at and why you're doing what you're doing, and it makes things simpler.
For me, I really don't have cravings that often or really at all, but like Wombly said, the intrusive thoughts come in, and it's like, man, that used to taste good or this or that, and pops in, and then instantly it's like, why did I think that? That's where I go with it. I question myself, like, why did I think that? Why did that thought pop into my head? And I instantly go to like, well, what's my feeling about that? Because anytime I used to want to use and everything, which was all the time, I was running from something, a feeling was happening, some kind of situation, got an emotion to come up, and I stuffed it. I wanted to shove it down as far away as I could to not experience it. So now I get right to experiencing my feelings, and I still try to stuff it. I still try to hold it down, and that creates my own misery, and it's a while before I reach out and talk to somebody about it some days. But to just start, like Wombly said, weighing the pros and the cons, the consequences. Like, I got so many things going on for me now in a good way that why am I willing to jeopardize it over something that I used to think was fun, when every single party that I ever went to, it started out one way and it looked like fun, but the end result was I was sick, sad, broke, sometimes laying in a gutter, sometimes I was rolled, sometimes I was all filthy and dirty, messy pants. Those are the realities of addiction for me. And to see the good time starts, that's me romanticizing about it. I go right straight to the end result, being homeless, wishing I was dead. I make that connection a lot quicker now, and that came with the Creator working and healing my brain to give me different answers and ideas on how to not go back to using, how to remember that my disease is telling me I'm not diseased. It's telling me I'm okay, I got this, I can do that. The Creator lets me know every day, He humbles me every day as soon as I get cocky or arrogant that, hey, I don't got this, and if I think I got this, I'm in trouble, I need help, I need to go somewhere. I need to maybe check back in and get a bed, because I don't want to use. I relapsed many times in my head. Mental relapse is real, it happens, and you don't got to use to relapse, and to be aware of that. That was huge for me to realize that. And it happens, but to have support groups, to support yourself, to support them, someone talks to me about their issues, that's bringing me up, that's lifting me up. I'm taking that and I'm running with it, and that helps me battle those thoughts and those urges.
For me, I'm very thankful for the long-term program that helped out a lot. But like these guys, I honestly don't get cravings like that anymore. I learned a lot during treatment because my cravings always they would start with a thought. And so when the thought comes up, I try to dismiss it, get rid of it, think of the consequences like Gifford was saying, and ask myself, positive self-talk, why? Why am I thinking about this? Look what it did to me before. And so for me, I always stop the thought, get rid of it, and I always pray. I always keep to the Creator and I ask for help. And it takes those cravings are pretty much gone. I have a switch. I tell everybody when I go to meetings that there's a switch that I did in my brain. I flipped it, and that I'm not going to use anymore. I'm saying no. I found my voice. I'm able to say no.
Any other questions? Okay, if not, let's have one more question. Yeah, that's better than payday right there. That's working in this field to see people actively engaged in successful recovery is awesome. So we're going to change gears. We're gonna change gears a little bit. Cardwell, CC, you want to come up here? And like I said before, this guy has no idea how influential he's been on me and also in our program. He's been very gracious, generous, and it just amazes me that somebody at his level and his caliber and stature genuinely cares about our clients and our program, and it just amazes me. He's available to us, and he's been real generous. He's published. He's got videos and DVDs and books, and everything that he has donated to our program. And I got him on speed dial, and if I need a consultation, he's there. So we just want to recognize him right now, and we have Russell Eaglebear we've asked him to, on behalf of the Rosebud Sioux tribe, we had a certificate of recognition for Dr. Knuckles. I was talking to Rodney Bordeaux about doing a presentation, and he said, let's do an official proclamation on behalf of the Rosebud Sioux tribe recognizing his contribution and effort. So I'm going to ask Russell if he would come forward and share a few words, and then we have her certificate, and then I've asked Mike Little Bear if he would do a prayer song. His deep sense of spirituality.
About the addictions that we have here among our people. Ed, get cowboy, but we can talk about that another time. But we are really thankful, you know, that you take the interest to come here and learn. I'm also really thankful for these young warriors that were sitting up here, really brave, coming out and sharing their experience. You know, we have many addictions. For the last 200 years, our people suffered from alcoholism. And now today we're into drugs, we're into meth, we're into pills. It's addiction, it's ongoing addiction. And we've been dealing with that for the last 200 years, and maybe it'll take that much time to actually come to senses about who we are as Lakota people. And we need to go back to the ways of our ancestors and how they survived and how they lived. And that means our spirituality. We have to find a way, a source, to have a belief in something, but also believing in ourselves because we have spirit. So it's going to be a long journey. You know, it's really sad when I see our young people getting addicted to meth. I'm sad when I see our young people committing suicide. It's all we can do sometimes is offer prayer. And prayer can see us through. In our lifetime, you know, sometimes we ask for things and we want it right away. We want it instantly. But prayer works in its own way to teach us a lesson, to teach us something positive. And so I urge you to continue what you're doing, learning, understanding, respecting what we're trying to do in life. With that, I really encourage our young people. This young lady here is going to read a proclamation from our tribal president. He could not be here, and I was telling the presenter that I was hanging around the tribal building, so they sent me as a gopher. But I am involved in this way of life too. You know, I've been sober for 37 years, and I try to help our young people through our spirituality. And I'm really thankful for all the work that this gentleman has done for Ed and our program and our tribe. So I'll turn this over to this young lady. She said she has a lot to say, but so I said, tell me in my ear and I'll say it for you. But
the Rosebud Sioux Tribe awards the certificate to Dr. Cardwell Knuckles in recognition of his generous contribution of time, knowledge of neuroscience, spirituality, and addiction. Mr. Knuckles has donated his audio, visual, and publications to support the treatment of methamphetamine and opioid addiction in the Rosebud Sioux Tribe Meth and Opioid Rehabilitation Program. Mr. Knuckles serves as a professional resource to the staff, providing technical assistance and expertise that enhances the program's effectiveness. Mr. Knuckles demonstrates a deep sensitivity to Lakota culture. The Rosebud Sioux Tribe honors Cardwell Knuckles and his relationship with the Rosebud Sioux Tribe.
I just wanted to thank Dr. Knuckles for coming out and educating us. And we've all learned that, you know, the purpose of any disease is to destroy its host. And that's usually us as people who continue to drink or use. But, you know, there's two choices that we as alcoholics, drug addicts have. We either get clean or we die. But Dr. Knuckles is educating us to help us, our relatives, to help them, to help them. So, we all know the 6 directions, the 4 cardinal directions, and 2 other directions. And we've always looked for happiness as addicts or alcoholics, traveling all these directions. So we forget about that sacred 7th direction. That's like God, Creator, Tungashi law that lives within us, that helped us to survive all through what we went through. And Dr. Knuckles has educated us in that sense to help others as well. So when we continue on with our life, we're fulfilling our purpose in life to help others. And I've heard that, that that we have to give back what we've learned so others may live. We do this so others might live. And it's a honor to sing for Dr. Knuckles. I'm just going to sing a prayer song. Ed asked me outside here, so, as addicts or alcoholics, we're critical thinkers, whether we know it or not. We know how to think. Think of last minute. So it's like riding a bike. You learn to change speeds. You learn to adjust to what you're dealing with. But and I'm from Standing Rock, so Mr. Knuckles has gracefully honored me with being here to be part of this workshop as well. And Ed, thanks Ed for being done. Let me come down here, but it's always got to good to be something part of positive. But when we finish our life's journey, we come from the heavens already as spirits. So we're here on a physical journey. So when we complete our physical journey, we go back into the heavens, completing fulfilling our purpose in life. And that spirituality has a lot to do with our sacred 7th direction. We always have to have that prayer, that spirituality that we've come to know. So when we become lost, we come back, we come back to the Hochoka, the circle of life, to live again. So, but anyway, I'm gonna sing a prayer song for Dr. Knuckles here, and asking Creator to watch over him, guide him, and protect him too. Yeah. Tunka she atoka he chewaki eo. Tunka she atoka he chewaki eo. Vitaku eo wanikta cha chewaki eo. Wakataka toka hea chewaki eo. Wakataka toka hea chewaki eo. Dacă tu ca și încă ne voce că am pentru că ne vopi la tanke, o iată că te watch că ne. O că ne o sape că o iată că e watch că ne. Că lagi oi chi mani et că ya ne. Voce că metaki api veni și ci at că ne prejuta și ce ne. O ki chapo ne. Că vopi la tanke ne. Ce chașe ce energie pone wangla că ne. Că Tungashi la un tanke la pete că vopi la tanke ne. Unchi inama kana ita wopi la tankana pejuto wasteate no oite chate wachik tena takatena tate topa ke wopi la tankana ekcho yate cha oichimani waste he wangla ke no kichapona ke wopi la tankana ampatikina akoicha kankena desawe waniki tiri takuitha taku wakan spanska Socha kecha. Oyate oichimani oche. He washte echa e ko. Echa wopi la tanka le ampetikina. We chose ani washte le ke wopi la tankina. We tako ye oasi. Oh my Lord. Yeah. Good.